most of the patients using rapid maxillary expansion and facial mask with McNamara system or with a different type of system. Maybe the most effective is in the primary and early mixed dentition. The great forward movement of the maxillary when we are combined with the facial mask and rapid maxillary expansion. Okay, we are using 5 or 600 grams per side, about 12 hours a day, normally almost during 1 year. And according with Peter Nagan, the maxillary effect and the dental and skeletal effect is about 60%. And mandibular, skeletal, and dental effect is about 40%. For this reason, in my office, all the patients with class 3 malocclusion used rapid maxillary expansion and facial mask, even in patients with mandibular problems. Why? Because according with Peter Nagan, the effect of the rapid maxillary expansion and the facial mask in the mandible, in the total treatment of the patient, is close to 40%. Remember this case. In the lower, you can see another patient with a very severe class 3 rapid maxillary expansion, facial mask, and what is the objective, the protocol in my office? Very simple. Between 8 and 10 years, rapid maxillary expansion and facial mask. About 1 year, 1 year and a half. 1 year is enough. Okay, 3 or 4 years later, I don't like to use retention. I don't like to use appliances between the first and the second phase. 3 or 4 years later, we evaluate the phase and the occlusion. When the phase and the occlusion is okay, we decide to treat the patient with conventional orthodontic. When the phase is not very good, but the occlusion is okay, I recommend to the patient, to the parents, to take a decision about the surgery or not, or camouflage. And when the phase and occlusion is not very good or bad, I prefer orthodontic surgery. For this reason, this is the typical patient with class 3, treated the patient with rapid maxillary expansion and facial mask. Now, 3 years later, it's time to put brackets in the upper and the lower, even to finishing the patient with a class 2 elastics. And the end of the treatment with a very good occlusion, a nice occlusion, and very good relationship between the maxillary and the mandible. Okay, when the patient presents a problem at the level of the face, depends of the quality of the life of the patient, the quality of the life of the patient, okay? And when the patient needs orthodontic surgery, I recommend to the patient orthodontic surgery. In general, I hate to camouflage the malocclusion when the malocclusion produces a very anesthetic face. For example, this girl. The main problem of this girl is not the occlusion. The main problem of this girl is the face. For this reason, we recommend in this patient surgery to produce a mandibular setback and at the same time to produce an mentoplastia, to produce the mentoplastia and the mandibular setback, and you can see the effect, the spectacular effect, the profile of the patient of our treatment. Another patient with an open bite, Is possible to treat this open bite with screws without surgery? Yes, it's possible. But the problem is the face of the patient, is not the occlusion. The face of the patient, when you treat this patient with orthodontic surgery, is completely different when the face of the patient before the surgery. You can see the change of face patient with the surgery was something spectacular. Another patient with a class 3, is possible to treat this patient with extraction of the lower premolars. Maybe we decide with the nemotech, to analyze this, the end of the occlusion of the patient, and the most important is the face of the patient. For this reason, the class 3 is the same if you are in the Roth technique, it's the same if you are in the Damon technique, it's the same if you are in the MBT technique, it's the same if you are in a classical tweed technique, it's the same if you are in the bioprogressive technique. It's very, very, very simple. What is the big problem in orthodontic? The big problem in orthodontic is the mandibular class 2. And we have a lot of treatment mistakes. Why? Because the different schools of orthodontic, don't use functional appliance. And this is a huge problem because without functional appliance, it's not impossible, but this is very, very, very difficult, very, very difficult to treat the mandibular class 2 with success, okay? Remember that in the classical evolution of the orthodontic, are we adapting the appliance to the malocclusion or the malocclusion treatment to our appliance? In my opinion, the worst problem in the history of orthodontic is the different techniques adapting the appliances, the headgear, to the malocclusion. For example, headgear is I like very much the headgear, okay, but headgear was very popular. All the class 2 treatment is with the headgear. All the class 2 is a maxillary problem. But even, for example, MBT, excellent orthodontist, Dr. Trevizy, Professor Trevizy, recommend to use functional appliance, for example, the twin block. What is the problem? I don't know what is the situation in Jordan, but in Spain, in Latin America, in the past was very popular to use functional appliance very early, maybe between the 8 and 10 years old, and finishing the treatment with fixed appliance about 12, 13 years old, and the complete treatment is 4 or 5 years. And this is a huge, huge problem. For this reason, what is the problem? The main problem is this. If you use functional appliance to stimulate the growth of the mandible, the theoretical stimulate the growth of the mandible, okay, if you put the appliance very early, okay, very early, this is a huge problem. And this is because this is the puberal growth spurt of the mandible. The puberal growth spurt of the mandible is very late. And we are talking in boys about 13, 14, and even 15 years old. And in girls, about 12. For this reason, it's not a very good idea to put very early functional appliance to move forward the man. The second problem is this. This is a very popular treatment in my office. This is a dental class 2, and very popular in my office to put brackets in the upper, to put brackets in the lower. And now when we are using thick stainless steel wires, we are using the class 2 elastics. And with the class 2 elastic, get a very nice class 1, good correction of the deep bite. Okay, nice. What is the big problem? The big problem is that 90% almost of the clinics in the world use the class 2 elastics only to correct the mandibular class 2. Because in the mandibular class 2, it's possible to need to distalize the upper molar. But the most important in the class 2 is to move forward the mandible, not the teeth, the mandible, to move forward the mandible. Okay, I would like to explain our idea about class 2 with this case. This is a patient with a class 2 division 1. The main problem of the patient is the retrusion of the mandible. Present is functional shift of the mandible to the left, a crossbite here. Okay. And I treated by my hands, I treated this patient. Start with conventional treatment with stainless steel 90 by 25, 21 by 25, and put elastic class 2 with curve of SP in the upper, more class 2 elastic with stripping, more stripping, more class 2, more stripping and control of the friction. We are using this type of bracket. This is the Synergy bracket from Rocky Mountain Orthodontic Company. And the big advantages of the Synergy bracket is the possibility to control the friction and the orthodontic tooth movement tooth by tooth. For example, in this case, we need the maximum control of the canine, the upper right canine, and I ligate the Synergy bracket in a figure of 8, in a figure of 8. This is a conventional, and if you need in the Synergy low friction, ligate the Synergy only in the central wings. Okay, you can see the result, a very fast treatment, very nice result, very nice smile. The patient, the parents is very happy, but please check the complete disaster of the profile. Was a complete disaster. Okay, this is a complete disaster of the profile. What was the problem? The problem was the attempt of the correction of skeletal class 2 only moving teeth. And this is a typical problem. Intrusion of the upper incisor with the stainless steel curve of SP, protrusion of the lower incisor. If you produce protrusion of the lower incisor, and remember in many techniques like the miraculous brackets, passive self-ligating miraculous brackets, do you understand what is the technique we are using? You can see in a lot of patients, the lower incisor at the end of the treatment present a very protrusion of the lower incisor. Why? Because in this technique, use a very bad control of the friction. It's a very nice technique to align the teeth, only for align the teeth. But in the most difficult phase of the treatment is finishing the treatment with the control of the torque. And for the reason, at the end of the treatment, you put a class 2 elastics and produce protrusion of the incisor. Please remember this disaster. And what was the problem? According with Samir Bisara, when the mandibular growth is tending to grow the mandible anteriorly, the occlusion produced is providing a force system to perpetuate the class 2. Why? Because the mandible push the maxillary forward and the mandibular forward, the maxillary forward, excuse me, the maxillary push in a reverse effect in the class 2 elastics and produce a posterior rotation of the mandible. This is a complete disaster when the patient is a dolichocephalo patient. For the reason, Houston, we have a problem because most of the cases, for the reason, the Roth guys and the Roth orthodontists say mandibular class 2 need orthodontic surgery. According with Profit, it's not possible to use functional appliance because the functional appliance only produce dento-alveolar effect. Okay. Mandibular class 2, we have a problem. What is the first step? I don't have a lot of time to explain this because we need for the mandibular a complete change of mentality. The first step is not true. The classification of maxillary class 2, mandibular class 2, mixed class 2 is not true. The maxillary class 2 always is a dento-alveolar problem. The mandibular class 2 always is a basal bone problem, okay? And it's completely different. We need a new classification. Why? Because the dental classification is very simple. Class 2 molar, canine, overjet, overbite, interincisal angle. But the facial class 2 is very difficult because it's a subjective, is in relationship with fashion. I don't like the classification, the academic classification, maxillary mandible mix, and I don't like, okay? I prefer to use maxillary dento-alveolar problem, and we need to treat the anterior guide and the dento-alveolar rotation and distalization of the first molars. The next is the mandible and the vertical, okay? There is completely different mandibular and sagittal class 2 problem than the vertical class 2 problem. I like very much this classification. This classification is in relationship with the syndrome. What is a syndrome? It's a set of medical signs and symptoms are correlated with each other and often with a particular disease of the cell. For the reason it's possible to have, one moment, a light class 2 or a severe class 2. What is a light class 2? It's a class 2 only with a molar problem. Next, molar problem and anterior guide problem. Next, maxillary problem. Next, muscular problem. Next, mandibular and body ramus problems. Next, chin problem. Chin problem is a huge problem. Why? Because chin is 100 genetic. 100 genetic. If the patient presents a retrognatic chin and is the morphology of the chin, the patient needs orthodontic surgery, even if the patient is 6 years old. TMG problems and or craniofacial or syndrome problems. For this reason, the molar class 2, very important, adjust the molar to know very well the role of the first molar in the patient, to know the Andrews keys, to know the ideal occlusion of according with Andrews, the rotation, very important, the rotation of the first molars, the cephalometric analysis of the patient. For example, in the maxillary problems, I recommend always to start treatment with maxillary expansion. Why? Because we need unlock of the malocclusion. We need to unlock of we need to unlock the mandible and to move forward the mandible. And for this reason, the first step is to put quachelis or to something to produce expansion. And next, the use of a utility arch to control the anterior guide. Okay, I like very much very simple treatment. Headgear is not a very popular treatment in our office because the patient and the parents hate the headgear. But headgear is very, very good treatment in the maxillary class 2 treatment. Why? Because it's very cheap. It's very cheap, produce an expansion effect, produce a distalization effect, produce this rotation effect, produce an increase of the vertical effect, and this produces a lot of advantages. For this reason, I like very much. It's very important to finishing very well the cases and to engage the first molar. Okay, this is I don't use the headgear, but I think it's very important to analyze the use of the headgear even in patient because it's very cheap and the effect is very spectacular. Don't use very sophisticated and very expensive appliance because you can see this case. It's a class 2, divide, collapse of the maxillary, and use only a headgear. Only, this is a headgear. Only with the headgear and with very simple appliance is enough to treat this patient. Okay, another patient. The main problem of this patient is this. The main problem of this patient is the class 2. First step, distalize the first molar. Second step, to close the space, the premolar and canine. What is the problem of this type of patients? We need a sliding mechanism. To a sliding mechanism, the best bracket is a passive self-ligating bracket. And the worst bracket is the conventional bracket. For this reason, I like very much the scenery, because with the scenery, if you need in the upper incisor the control of the torque, it's possible to ligate in this way, but if you need in this moment to move backward the canine, the premolars, ligate only in the center. You ligate only in the center the canine and the premolars, and the friction is close to zero. It's close to zero. Another patient, very simple treatment, maxillary dental class 2, very simple. Okay, what is the problem of this patient? The shift of the upper midline to the left. For this reason, what is the problem of the shift of the upper midline? Very simple. The problem is this. What is the treatment? The treatment is to put brackets in all white into the mouth, to put brackets very fast, a coil spring. Not. The first step is to put the first upper molar in the correct position. In this case, we are using the upper pendulum appliance to distalize this molar. The end of the treatment, and you can see the ideal correct position of the second upper premolar, of the second. More cases, class 2, division 1, dental class 2, not mandibular problem, dental problem. The ideal treatment for the dental problem of the class 2 is the class 2 intermaxillary elastics. In the technique we combine in the anterior incisor ligate in the figure of 8 to cross, to increase the torque, to control the torque during the retraction of the upper incisors, and the canines and premolars ligate in the center to get a very good sliding of the wire and move the wire to the back. Okay, very important in this patient with dental class 2. Please check the rotation of the molar, check the position of the second premolars, and check the uprightening, uprightening of the lower premolars and the upper. The same here. A patient with a rotation of the upper molar, rotation of the upper molar. Okay, we need to distalize the premolar. We need to distalize the premolar. Okay, using a pendulum appliance. We use a pendulum appliance to the first step is to correct the first upper molar. Now we are using intermaxillary elastic to engage the occlusion. Okay, very simple, very important. Now, to move canine and premolars to backward, we are using the finishing the treatment. And the most important is this. You can see before the treatment, the upper midline shift to the right with a crowding, with a narrow maxillary. And now you can see the face at the end of the treatment with a very nice smile, with a very broad arch. Next, the same, quite simple. Simple, because in this patient, what is the problem? The problem is this. The problem is the canine, but we need to move backward the molar. The first step is a palatal bar to the control of the first upper molars. Next step, remove this more temporary molar, put a coil spring, a night-tie coil spring to distalize the premolar to produce a forward movement of the lateral incisor and to correct the crossbite of this tooth. Now it's time to put class 2 elastic because the patient presents a dental problem. Okay, shift to the class 2 elastics and finishing the treatment. The same, the big advantages is this. The shift to the mandible, the upper midline to the right. Now we have a very nice upper midline without extractions and with a very nice control of the premolars and the canine. Another patient with a crossbite, okay? The crossbite in the right. And we need now to the crossbite, we put the elastic in the upper and in the lower. We use the quachelis to expand this molar and to control the expansion with this type of bypass arch wire and the end of the treatment. And you can see the nice smile of the patient, okay, because the patient presents a class 2, dental class 2. Even in patients with with a collapse of the maxillary, with a problem in the maxillary, we are using rapid maxillary expansion and a very good control after this rapid maxillary expansion, a very good control, a very good negative control of the molars and the premolars. Okay, remember this, the occlusion of the patient, and remember the Andrews keys, the incisal angle, the inclination of the second order burns, the Monson and Wilson curve, and I like very much, for example, for the diagnosis of the class 2, this diagram. This is a patient, okay, and this is the distance between the first molar and the pterygoidea vertical line. This distance is the age of the patient more 3 millimeters. And this is the distance between the molar and the lateral incisor. It's about 25 millimeters. When the patient presents a rotation and mesialization of the first molar, okay, increase the age and 3 millimeters, increase this distance and decrease this distance. What is the plan of treatment? The first step is to put the molar backward to control the molar. For this reason, I like very much this diagram. For example, in the number 1, the patient present class 2 in the right and class 1 in the left, okay? And this is the, according with this, only the problem is in the right, not in the left. Only the problem is in the class K9, class 2 in the right, not in the left. Overjet is normal, IMB is normal. The distance between the molar and the vertical line is increased only in the right side. For this reason, what is the treatment? Very, very simple. The treatment is only the treatment of one molar. You need to correct the first upper molar, correct first the molar, second the premolar, and third the canine. But in the third case, class 2 in the right and in the left, class 2 in the canine are right and left, but the distance between the molar and the lateral incisor, the distance is completely normal. And the distance between the molar and the pericoideal line is also normal. For this reason, what is the problem of this patient with overjet increase? Class 2 in the right and in the left canines. The plan of treatment of this patient is to move forward the mandible. Okay, to move forward the mandible. For example, in patient like this, with a protrusion of the maxillary, what is the treatment? The treatment is the use of the C modeler for Cervera to correct the protrusion of the incisor, to correct the overjet, to control the growth of the mandible. And now it's time to finish the case. Remember this, the hypothesis, the Melvin-Moss hypothesis, the proprioception occlusal hypothesis for Petrovic, the connection between the mesencephalic nucleus and the change of the dynamic of the mandible, the relationship with the functional appliance and the appliance that is possible with this appliance to stimulate the growth of the mandible. Okay, and you can see here in many cases it's possible to change the face of the patient with a rapid maxillary expansion. I like to use the rapid maxillary expansion in these patients, okay, to change the upper airways. Like in this patient with a maxillary collapse, we are using the rapid maxillary expansion and expansion very fast the maxillary. And in my office, it's very important the diagnosis of the patient. Remember also this. Remember the tongue, the role of the muscle, okay, of the patient. Remember this, that this is very, very important, and to understand how to work the functional appliances, okay? How to work the functional appliances. For this reason, what is the philosophy of the treatment? The genetic...
Sorry,
yes.
We have 5 minutes.
Okay. Do you know something?
Sorry?
Yes.
5 minutes we have.
Okay. One moment. One moment. And what is the for example, the treatment in our office? What is the, one moment, the classical treatment is this. One moment. Okay. Okay, the idea is very simple, is this. We treat with a functional appliance, stimulate the growth of the mandible, but at the same time stimulate the alveolar bone, apical, okay, to the teeth. Okay, this is the idea, to stimulate the alveolar bone here and here, and to stimulate the growth of the mandible. But remember that it's not true, it's not possible to stimulate the growth of the mandible, of the basal bone of the mandible, or only to stimulate the mandibular with the condyle. For this reason, in a patient, the treatment is to correct of the molar. Second, to correct the bite. Third is to put functional appliance. Okay, and this is the, for example, a patient. We use the first step is to align the teeth, to increase the overjet, to create the space to move forward the mandible. After we use the twin block, and we use the twin block, the digital or conventional twin block, at the same time that the brackets and the wires. Now is a new periodontal proprioception, stimulate the new periodontal proprioception, and now the patient present the jumping the bite. This is a concept from angle. Jumping the bite. The patient jumping the bite now is not in a true class 1. It's like a false class 1. But in this moment is the moment that we are using a lot of class 2 elastic, short and heavy. And with the use of this class 2 short and heavy elastic, finishing the treatment. And this is the retention, because we finish the treatment very early. We use like a retention, a functional appliance to avoid the relapse. This is the patient years later, and the patient years later, and more years later. Another patient, the bite, collapse of the mandible, retrusion of the mandible. If you analyze the nasolabial angle, is a mandibular class 2. Okay, this is our analysis or forecast for the treatment. The objective of this patient is, the first step is to produce a protrusion of the upper incisors, because we need to move forward the mandible to avoid the disaster of the patient that we show it at the start of the lecture. Okay, the idea is this. Okay, now we have to analyze the cephalometric analysis, maxillary expansion, control of the incisor guide, mandibular unlock, first jumping bite, second, the use of functional appliance, second jumping bite, and finishing with the technique of alignment, leveling, closing space, and finishing with the straight wire, low friction with the synergy bracket. We use for the maxillary expansion equihelix, for the incisal guide bypass arch wires, for the functional appliances, Frenkel, Bimler, or another type of Frenkel. We use the combination between the twin block, the bionature with first equihelix, second the bionature with brackets and wires. And you can see here, finishing the treatment very fast. Okay, and you can see the face of the patient. It's completely different, this type of patient. We produced, the first step was the protrusion of the upper incisor. The second point was the use of functional appliance to stimulate the growth of the dentoalveolar growth of the mandibular bone apical to the teeth. This is the patient, and you can see the patient 3 years after the treatment with a very stable occlusion, with a very nice occlusion, with a very good engaged and very good dynamic occlusion. This is not a 100% of stability, okay? Because in many cases it's not possible to stimulate the growth of the alveolar bone or the mandible, but in our hands, the best result to treat patient with mandibular class 2 is the combination between the use of functional appliance and the fixed appliance. The ideal in the future is the digital functional appliance. This is the ideal for the future. Okay. Okay, I have more cases, but I prefer if you want questions. Okay.
Okay. We have like one question, and I'm going to ask you the first question if you don't mind. Now, regarding the clear aligners, which age do you prefer to start in for children? And does this kind of manufacture, do you manufacture it in Europe?
No, I don't manufacture. This is manufactured in a company in Spain, in Malaga, in the city of Malaga. The name is Alinea Dent. I don't have experience to manufacture the aligners at home, okay? Because the main problem with the aligners at home is the price of the resin, okay? It's not very easy to organize the aligners at home. Maybe in the future, with depend of the price of the printing. The idea is if you are using, for example, Invisalign, you have Invisalign kits. The idea of Invisalign kits is to put all the treatment of the patient using only aligners. My idea is different. The idea is to put in the first phase of the treatment something very simple, 4 brackets, 1 quachelis, 1 lingual arch, and using only the aligners in the last phase or in the last part of the mixed dentition. Immediately before the loss of the exfoliation of the second temporary molars and before the eruption of the upper canine.
Okay, let's go for the second question. It's Dr. Riyad. Let's unmute.
Yes, I will do it. Just a minute. دكتور رياض تفضل لو سمحت.
Thank you for your lectures.
Okay, thank you.
First part is that your lecture, the title of it is to use a liner in children's, in mixed dentition, right?
Only, yes.
Yes. So we have a problem with adults, with the cooperation to use a liner.
Yeah.
When you give a liner to children's, usually you have a problem that they will not eat it. So instead of this, we can use, as you said, any type of fixed appliances and get the result. So there's no need to use a liner in mixed dentition, and because the cooperation of the children is very difficult.
Yes. The question is very simple. If you put aligners in children, the first you put aligners with the idea to put all the treatment with the aligner. The big problem is this is very unstable, the aligner, and the kid remove the aligner. But we are talking about to put the aligner only during a very short period, maybe 6 months, 1 year even less, because it's between the loss of the second temporary molars and the eruption of the upper canine. It's a very short period. In this short period, it's possible to get a very good retention of the liner. Even in my experience with the liner in kids only in this period is very good.
I think that we can finish the case with fixed appliances, and that's it. There's no need for aligners with the kids. The kids, they are uncooperative to use a liner. Yeah, we have this problem. The second part, that cover everything. You cover class 2, class 3, functional appliances, headgears. Nowadays, 90% of orthodontics, they don't use headgears. They use the implants, distalization. I'm
yes.
with functional appliances with you. I'm also with you to use a face mask in young children's rapid maxillary expansion. But in the same times, you cover everything. This is, yani, I don't think that what you are dealing with is that what type do we have at this lecture? Is it lectures for early treatment or is it lectures for everything? I am sorry to say that.
No, the question is very simple. The question is, the first step is I use a lot of mini screws. In fact, I have mini screws, and I use a lot of mini screws. The lecture is two parts. The first part is about the mixed dentition, and the second part is the class 2 treatment in the class 2 treatment. In my office, we treat the patient of class 2 with functional appliance and fixed appliance at the same time. Another question is the cooperation. Okay, in my office, I use a lot of functional appliance, and I don't have problems with the functional appliance. A lot of people talk about, I have a lot of problems with the kids because the kids don't use the appliances. It's not possible to put removable appliances in the kids, or it's not in my office. I have a good, because the main problem in orthodontic today is how to move the mandible forward without functional appliances. Not because Forthus or another type of appliances like Forthus, they produce a dental-alveolar protrusion of the lower incisor. This is the question.
دكتور شادي تفضل. دكتور شادي بده يسأل سؤال. Dr. Shadi has a question.
شكرا. Yes. Thank you, Dr. Majd, and thank you, Dr. David, for the informative presentation, as always. Actually, there was a question in the Q&A tab, but I think it was similar to Dr. Riyad's question, so we'll consider this answered. But I do have a question of my own, if you don't mind, and it's also regarding the treatment of kids in the mixed dentition with the aligners. So you mentioned that you actually reproduce the shape or the size of the unerupted teeth during the mixed dentition as you're treating with aligners. So can you just give us a brief, quick note about how you actually reproduce accurately the actual size, and do you actually have to take rescans or new impressions?
Well, the question is very simple. The question is, there is two possibilities. The first possibility is more sophisticated, and you can see here with the the first question is the ideal is to use a CBCT. Okay, you take you take the shape of the teeth. Another very simple is to take the opposite tooth, or to use a tooth very similar in the shape in a bank of tooth, and to put in a bank of tooth, and to more or less to put in the space for this tooth. Okay, it's possible. The ideal is with the CBCT, but it's not necessary. It's possible to put with a bank. For example, imagine that you have the eruption of the first premolar in the upper. It's possible to use the first premolar to create the shape of the canine.
Yes. Okay, but is this really accurate towards the later stages of the treatment when you want to fine-tune the position of the tooth? does it have
more or
any
less,
effect on the
because
finishing?
you need more space. If the canine, the measurement of the canine is 8 millimeters, you need to put more or less 10 or more. Okay.
Okay, thank you. Thank you very much.
Okay, thank you very much, Dr. David Suarez, for your beautiful lecture tonight.
Thank you.
It was our real pleasure having you twice this month. Hopefully we will meet you soon. Okay, have a nice evening. And my dear colleagues, thank you very much for attending tonight. Happy Ramadan. كل عام وانتم بخير. رمضان كريم. إن شاء الله نلقاكم في القريب العاجل. كل سنة وانتم سالمين. Dr.
Thank
David,
you. Thank you very much, and happy Ramadan. Okay.
Thank you so much. Thank you.
Thank you. Thank you. Thank you very much.
Goodbye. We'll be ending the meeting now. Thank you very much.
Thank you. Thank you. Thank you very much.
Thank you. اوكي وير لايف برضه هنا على الفيسبوك. نرحب معنا دكتور عبد الله حلحولي، دكتور اكرم الطواشي، دكتوره الهام عبد العزيز، دكتوره لبنى ابو الرب، دكتور محمد مداد، دكتور محمد النذير، دكتور محمد خليفات، معتصم العبد الله مع حفظ الالقاب، دكتوره منى جبرين، دكتورة نانسي السرايرة أهلا وسهلا، دكتور نضال غنام، SA عمري ما بعرف مين SA عمري، دكتور سامر صناع، دكتورة سيرين بدران، دكتور شادي الحوراني، دكتورة سجود فايز، دكتورة زها عمرين. أهلا وسهلا. نرحب نبدأ إن شاء الله هلأ بمحاضرتنا لهذا اليوم. نرحب بالدكتورة عبير الحديدي. الدكتورة عبير الحديدي is an assistant professor at the Department of Oral Surgery and Oral Medicine, Pathology and Periodontology at the School of Dentistry, University of Jordan. الدكتورة الحديدي received her DDS degree 2004 من الجامعة الأردنية and certificate and MS degrees in oral and maxillofacial radiology from the University of North Carolina at Chapel Hill ب 2010. She got her PhD بال 2014 من King's College, University of London, completed fellowship and oral and maxillofacial radiology at the University of UNC اللي احنا already حكينا عنها اللي هي University of North Carolina طبعا. And she's currently the adjunct assistant professor there. In 2011, Dr. Hadidi became a diplomat of the American Board of Oral and Maxillofacial Radiology. She's also got her Jordanian board certificate in the same specialty. Her research was always focused on the use of 3D data and 3D image analysis in treatment planning of corrective surgical procedures. A PhD was done on the use of 3D image analysis in the diagnosis and treatment planning of mandibular asymmetry. نرحب بالدكتورة عبير الحديدي. أهلا وسهلا فيكي مرة ثانية بجمعية تقويم الأسنان.
يا مساء الورد يا مساء الورد. الله يعطيكم ألف عافية، وبتمنى إنه أنتم وعائلاتكم بأحسن حال وأفضل صحة يا رب، وإن شاء الله يا رب يشدوا وتزول وبنشوف بعض in person قريبا بإذن الله. إذا بتسمحوا لي اليوم I'm gonna go through CBCT application in orthodontics. في البداية رح نحكي شوية عن البيسكس of the technology، رح نحكي شوية عن بعض التكنيكاليتيز والbiological aspects of CBCT that would lend it suitable for dentistry in general or orthodontics in particular, and then we're gonna dive into the position paper of the use of CBCT in orthodontics. I'm gonna share some cases with you guys عشان نفتح نقاش about the importance and maybe relevance of the use of this technology in the orthodontic practice. So زي ما حضراتكم عارفين ال CBCT is a technology that is based on a wide cone beam rather than a shallower flat fan beam. It uses an X-ray source. It's a much cheaper, more prevalent, and gives a less dose of radiation as opposed to multi-detector conventional CT scan. And that makes it really significant for dentoalveolar applications. The field of view of CBCT is very flexible as well, وهاي شغلة كتير مهمة. يعني you could actually capture as big as a large field of view, which would have the whole craniofacial area in the field, or you may go with a maxillofacial field of view اللي هو أصغر شوي that contains the maxillomandible. Sometimes this has the TMJ included, sometimes not. Sometimes you may opt into a much smaller field of view where you capture few teeth, سنين ثلاثة, and most people that use that would be looking into an endodontic application. فهاي الفlexibility is very important, especially in orthodontics. فزي ما عم بتلاحظوا, we may look into a large field of view, medium field of view, or a small field of view. بالorthodontics, we're looking into a large and medium field of view being in the major focus. في some technical differences between conventional multi-detector CT and a cone beam CT that would be relevant in the use of CBCT in the dentoalveolar area. Multi-detector CT would use a fan beam, which means it would take a slice per slice individually. On the other hand, a cone beam CT will use a much larger X-ray source, meaning أنت عم تاخذ the whole head and neck area in one rotation. وهذه رح نرجع لها in specific, بس نبلش نحكي عن radiation biology with those aspects of both technologies. However, image characteristic of CBCT and CT in general could be actually looked at بطريقتين أساسيتين. الطريقة الأولانية هي contrast resolution, والطريقة الثانية هي spatial resolution. الcontrast resolution هي قدرة الإيميجينج سيستم بأنه يحدد الديفرنس between two structures, two types of tissues بناء على الدنسيتي والثيكنس تبعهم. وهذه is generally a function of signal to noise ratio. إذا بتطلعوا على هذه السلايد, signal to noise ratio profile of a multi-detector CT is much better than the signal to noise ratio profile of CBCT, which means in a CBCT has a worse contrast resolution profile. What does that mean? That means if I'm looking into a radiographic task, an interpretation task that would necessitate me إني أعرف الفرق ما بين two different types of tissues, ما في داعي أخذ cone beam. And I would need that in most soft tissue imaging. إذا عندي soft tissue mass in the tongue أو soft tissue mass inside of a salivary gland أو تفاصيل soft tissue capsule of a temporomandibular joint, then I'm probably not gonna use CBCT. However, one of the major advantages يعني نقاط القوة في الcone beam CT هو resolution contrast تبعه. Resolution contrast is a feature of the imaging technology that would allow me to tell small structures apart even when they're close together. فزي كأنها بتقول لي قديش في تفاصيل أنا بقدر أشوفها بالصورة. وبالcone beam CT I can actually see more details. Probably most of us in dental specialties would actually need the spatial resolution rather than the contrast resolution, because I want to know تفاصيل الكورتيسيس, تفاصيل علاقة بين التوث والبريدونتال ليجامنت سبيس, إذا عم بحكي عن structural changes اللي أنا بشوفهم مثلا around a root of a tooth right next to an impacted tooth, أو structural changes بالcondylar head for example. هدول كلهم radiographic tasks that would need spatial resolution, which is great because the CBCT would have the spatial resolution that we need for these tasks. Ishitani, that is also of a major importance in choosing a radiographic technique, is the radiation dose. Especially for you guys as orthodontists, لأنه معظم السامبل اللي بتشوفوها your patients are on the younger side. And definitely we're going to be even more concerned about radiation dose. Of course, you would use a higher radiation tool if you need that extra radiation dose, if that dose will actually bring you more important answers about a question. However, if I'm comparing two radiographic modalities that will give me the exact same outcome, I'll definitely will go with the lower dose modality or technology, for example. One way of looking at those is background radiation. هلا احنا مجرد ان عايشين فوق سطح الارض ايام ما كنا نسافر من بلد لبلد. The fact that التراب موجود فيه radioactive material, some food that we eat have some radioactive material. احنا عم نحصل radiation just by being alive. فبالpublications لما يحكوا عن radiation dose مرات they try to equate how much radiation dose does this modality have in comparison to 1 day of natural exposure, I would say. For a typical cone beam CT that involves the maxilla and the mandible, that's almost equal to 8 days of background radiation. And in microsieverts, إذا بدنا نحكي شوي technical أكتر, in microsieverts هدول ما بين 70 وال100 microsievert. بس إذا بدنا نقارنهم ب how many days أو how much radiation dose would a STT that involves the same structures اللي هم الماكسيلا والماندبل have, أنت عم تحكي عن multiple folds. أنت عم تحكي على بين 1000 و 1500 microsievert مقارنة بين 70 و 100، وأنت عم تحكي عن 256 days أو 170 days of background radiation مقارنة ب 8 days of background radiation depending on قديش الfield of view or which machine are we talking about. So if we needed 3-dimensional imaging, then cone beam is probably where we need to go. If we do not need 3-dimensional imaging, then a panoramic or maybe plus minus a cephalometric will be the way to go. And sometimes we may not need imaging for an answer of a clinical task. لأنه for example, a digital panoramic ما بين يعني ال 12 وال 15 microsievert, and that's equal to 1.7 days of background radiation. فهي هيك to get a feeling of يعني how much radiation dose am I thinking of giving my patient. Applications of cone beam زي the application of any radiation of any radiology technology that is out there. So implants هي driving force, بس يعني you use it to any developmental anomaly, impacted teeth including the third molars as well, periapical endodontic applications, temporomandibular joints, trauma patients, all types of pathological findings, and definitely orthodontics and airway space is one very important clinical use for cone beam CT imaging in the dental practice. There's a very important paper that I usually go by that looked into the clinical recommendations regarding the use of cone beam tomography in orthodontic treatment, and that's a position paper that was written by the American Academy of Oral Maxillofacial Radiology. Half the authors هم radiologists, half the authors from the orthodontists as well. So there was contribution من the American Academy of Orthodontics in that regard. So they looked at the use of CBCT in all phases of treatment and in multiple scenarios as well. فبالأول they يعني try to emphasize that زيها زي أي imaging modality تانية, the decision to perform that examination needs to be based on the patient's history with clinical examination. إذا المريض عنده previous radiographic imaging, هل في clinical condition معين where you really need extra imaging to be done, and also you need to always outweigh the potential risk of exposure to radiation. Always, if you can get your answers or your questions answered by a lower dose conventional imaging, go for it. If you take a panoramic and the panoramic would suffice, then there is no need for cone beam CT. لسه كمان هذه بنحكي فيها أكثر لقدام موضوع ال virtual orthodontic study models, بس لسه عم بيقول if you can actually perform the task without even ionizing radiation, then أحسن وأحسن. So if you can actually solve your problem, obtain the data without giving your patient radiation, هذا بيكون the ideal situation. تمام؟ هلا when you decide to use a cone beam, بالذات بالأورثو لأنه we're always dealing with younger people, you kind of have to look into the details and try to minimize the radiation dose, whether you want to optimize the field of view, بلكي minimize the exposure one way or another, and all that. هلا بالنسبة يعني في كتير أشياء that you can control if you work in a hospital base والcomb beam جنبك. However, if you're a dentist that is referring out, أحسن طريقة to actually govern هدول الديتيلز هو the choice of the proper field of view. لأنه مش كل مرة مريضك لازم ينبعت عشان يتصور comb beam. You have to include كل الماكسيلا والماندبل أو كل الهيد and neck area. So you probably want to be more specific about what question are you trying to answer. We try to limit that field of view لهديك المنطقة that you're interested in. هلا of course do not take a comb beam just عشان بدك تريح حالك and to get a lateral ceph or a panoramic out of them. وبنفس الطريقة if you really think your patient would need a comb beam وبدك تاخذ medium field of view comb beam ما في داعي تاخذ panoramic وcephalometric to start with. يعني إذا أنا مريضي already مثلا craniofacial deformity أو cleft lip and palate patient, I would probably skip the panoramic part and send my patient to get CBCT done وبعدين get my two-dimensional imaging reformatted from that existing comb beam. حلو. هلا معظم الساينس والإيفيدنس بالليتريتشر على يعني الامبورتنس وال زي ما تقولوا الفائده من استخدام الكومب بيم in the orthodontic patients تقع بالimpacted teeth لانه location orientation of those impacted teeth, the morphology of them, relationship to vital structures, path of insertion, وال presence or absence of root resorption of adjacent teeth. أنا تعلمت من زملائي الأورثودونتست إنهم بيلعبوا a major role in the treatment planning, the prognosis, whether I'm gonna try to bring it in the arch or maybe take it out surgically or maybe just leave it in place and not do anything about it. فهدول الpoints اللي عم نحكي عنهم are very important to tackle and هم very important in the treatment plan, in the overall prognosis of the patients as well. فمعظم كيسات الامباكشن I would say من الليتريتشر ومن الكلينيكال براكتس ومن اللي علموني يا زملائي الأورثودونتست would actually benefit from a comb beam CT. So whether I'm dealing with complicated cases, multiple supernumeraries, all of them are impacted, such as this example of cleidocranial dysplasia patient, where we have multiple supernumeraries, or some of them may have potentially cystic degeneration around them, وفي عنا proximity to a canal. بclinical situations زي هيك there is a lot of decision making to happen لأنه هون an orthodontist is going to be on board, an oral surgeon needs to be on board, وبالمساعدة radiologist we're going to have to think about كتير شغلات. We're going to have to think whether we need to leave some of those teeth, if we're leaving any of, if we're taking some out, which ones need to come out, if we're thinking of complete rehabilitation, are we thinking of potential implant therapy later on in life. فكل هاي المعلومات a comb beam CT will probably be able to help shed some light to try to solve some of those dilemmas. هلا مرات some of those impacted or even partially impacted teeth, malpositioned teeth maybe, they could appear simpler. يعني for this young lady كان في عندها buccally placed canine. Yeah, it does not sound, it seems to be of a big clinical problem. ولكن طلبوا لها comb beam for her impacted wisdom teeth. حلو. وبصراحة أنا ما كنت كتير متحمس حتى شفت هذا المنظر. So the root of that buccally displaced canine was devoid of bone. It was all the way out. هلا أكيد كلياتنا بلشنا نصفن في الموضوع إنه this tooth is probably not as easy as you know any orthodontist would say لأنه يعني it's not gonna take only 9 months if you're gonna even attempt to align it. يعني I'm worried about the vitality of this tooth. I'm worried about the buccal support. Is there going to be any bone buccal to it even if I try to align it? And if I try to align it, would it even stay in place or would it start being mobile? So يعني في كتير معلومات أعطتني إياها هذه ال overall look of the comb beam that may help me change my mind. طبعا بعد ما أكون شارح للمريض والجارديان تبعه التفاصيل لأنه يعني هذا المنظر would actually help your patient be an active member بالteam of the decision making لأنه مرات you really want to have that conversation ويكون collective decision. فإذا بتسمحوا لي I'm gonna just show few cases of impacted teeth case. Some of these are just regular impacted teeth and some of those are supernumerary. Let's see if those cone beams were helpful or not. So these are a couple of supernumerary teeth that are situated right palatal to both central incisors. حيكون ببال الواحد multiple questions. أولاً situation of the impaction. How close are those teeth to the roots of the central incisors? شو situation of the roots of the central incisors من ناحية development, من ناحية closure of the roots, من ناحية shape as well. Are any of these roots dilacerated or not? And this is a volume rendering model. هذا بعطيني هيك an overall look of maybe relationship, overall look about the morphology of teeth as well. ولكن أنا when I go over and see my cone beams, I actually use the actual data. On this upper right corner over here, I see an axial cut. And then this is correlated by a reconstructed panoramic, and I can see a buccolingual perspective of those supernumerary teeth. Now I can tell, are they close to the roots of the natural teeth? I can tell if what's the nature of the roots of those supernumeraries, and I can tell whether the roots of the natural teeth have been affected by external root resorption or something like that. And so if you see that the upper one is looking at the upper left central and the associated supernumerary, and we can see below the same representation of the supernumerary on the right-hand side. See a couple of supernumeraries on the mandible as well, with the mandible having the ID canal and the mental foramen. Also relationship to vital structure comes handy because, after we decide whether these teeth are to stay or to go, we'll probably want to look into surgical approach, whether, maybe a different surgical technique needs to happen, whether that patient may need more than local anesthesia during the operation. So we look into these teeth, and again, this is the axial cut, and this is correlated with the reconstructed panoramic. And I would like to ألفت نظركم للخط البرتقالي هون that corresponds with الأكسل cut up here والخطوط الخضر الconsecutive هدول they correspond with the specific cross sections that we see on الطرف اللي على اليمين. تمام؟ النمبرز that are up here they correspond on النمبرز اللي جايين على الارش because الارش كمان مرقم زي كأنه مرقم مسطرة ومعظم السوفت ويرز will give us that sort of correlation لأنه بال 3D imaging في more data than we usually see أو encounter on our panoramic or regular cephalometric. So we always have to keep coordinated عشان not to lose our geographic location عشان الواحد not to get confused على أنا وين بطلع وين بكل وين palatal. So you always want to try to correlate كل الفيوز مع بعض. And this is a good look of the supernumerary teeth on the left-hand side. This is the volume rendered from an occlusal perspective. This is giving us one side, and this is looking at the other side. So proper characterization of where their teeth are and their relationship to adjacent teeth and to vital structure. This is another example of an impacted canine. Also, how much buccal bone there is برضه has been a very important prognostic factor. And that probably will change your decision on the mechanics used and whether more bodily movement needs to happen وكل هاي التفاصيل التقنية اللي حضراتكم تعرفوا فيها أكثر مني بكثير. Also زي ما اتفقنا the presence of potential external root resorption on adjacent teeth would also بيأثر على البروجنوسيس وبيأثر على الميكانكس as well. So هون close up عم بيورجينا intermediate I would say external root resorption that is affecting the buccal surface of the root of the lower left lateral incisor. تمام. And this is the volume rendered appearance of that buccally impacted canine, in almost transposition as well. This is another look into another supernumerary and associated impacted teeth. Also, the relationship of those supernumerary teeth and impacted teeth to the nose are usually interesting as well, because that's, it may need a slight change in the surgical technique as far as accessibility to that. أخيراً وليس آخراً, sometimes impacted teeth are associated with pathology, يعني هم ما بيكونوا impacted because of space issues أو because of root morphology problems, لا بيكونوا being impeded, physically impeded from actually erupting. And this is a good example of an odontome. This is a complex odontome to me, and that explains why that second molar failed to erupt. So ما ننسى إنه our patients can actually have diseases that we may need to be able to figure out looking at a three-dimensional image. Other things that are important are craniofacial deformities, including cleft lip and palate and all the other syndromes that you guys sometimes see in clinic. We have a lot of softwares and a lot of effort in technology that actually trying to provide more tools for us to be able to, I would say, deduct more info from our three-dimensional image. Because, looking at the cone beam is very, very useful. However, if we can deduct more information, whether about the morphology of the head and neck areas of the patient, or whether something has to do with the soft tissue as well, that would probably be an added benefit to our patients, especially if we go into the orthognathic surgery kind of work. So there are multiple softwares that would have additional three-dimensional cephalometric capabilities, Dolphin 3D being one of them, and it helps into having all those modules that looks into the temporomandibular joint, and maybe an orthognathic surgery type of module. Materialized also has those modules that go in the intersection between orthodontics and surgery, with all those reconstructed work and all those syndromic patients, which actually may be useful, and that goes into the digital dentistry world with designing and printing missing pieces or intermediate tools, I would say, in the treatment plan. Virtual study model has been kind of one of those interesting things that we can deduct out of a cone beam. I personally have a lot of reservations in this particular use, I would say, because of two reasons. Number one, if some people بلشوا ياخذوا cone beam كجزء من convenience، انت you get a cone beam بعدين بتطلع منها virtual study model، بتطلع منها panoramic، بتطلع منها cone beam، وللأسف scientifically هذا مش good enough reason. it has been زي ما تقولوا misused. Also, on the other hand, I have much better alternatives of getting a virtual study model, which is intraoral scanning. intraoral scanning would give me a much better quality بالstudy model, quality بتكون أحسن using zero radiation. I would probably personally would rather إنه أستعمل better quality with zero radiation. However, if my patient really needs a cone beam وأنا أخذت الcone beam for a valid reason, ما عندي مشكلة إنه to try to look into this as an extra benefit، بس مش السبب الرئيسي أو أعتمد عليها أعتمد على الكون بيم عشان أطلع virtual study model. That's one thing to consider. A cone beam could actually be زي ما تقولوا base عشان أنا أركب عليها other clinical input زي مثلا 3D photography، وهذا بيساعد إنه أدخل treatment planning of the soft tissue on top of the hard tissue, bone and teeth underneath. So you can always merge a cone beam CT with a 3D photograph extraoral and intraoral as well. لأنه I can also take an intraoral scan and merge it with my comb beam as well. فهذا ممكن يكون useful. Those third-party softwares will actually be able to deduct a lateral or a PA cephalometric radiographs from the comb beam data set, if needed, of course, and if the comb beam was called for in the first place, for sure. Sometimes comb beam could be useful. I know a lot of people would say, mini screws عبير, not really, it's such an easy thing to do. Maybe I don't want to إني أعرض مريضي خاصة for young people. I totally agree with you. But if you're using a plate مثلا, if there is something interesting regarding the root morphology أو يعني shape of that arch, يعني something that is شوي out of normal. There are numerous articles بالliterature عم تحكي عن potential use of comb beam if you're thinking about extra anchorage that is derived from the bone عشان تعرف وين تحطها ويعني ما تعمل damage to adjacent structures for sure. Airway assessment has always been interesting. يعني إذا بلشنا نقرأ الليتريتشر قبل 10 سنين مثلا, there was a huge drive about let's dive more and look more into the morphology of the airway, the volume of the airway, the cross-section of the airway. There was a lot of effort into trying to combine that with potential sleep apnea signs and symptoms, maybe with potential morphological facial profiles. وهذا الحكي يعني عم بتطور, يعني every now and then بتبلش في groups جديدة عم تشتغل عليه. بصراحة الليتريتشر مش متفق. يعني you may read a lot of pieces that would say this particular feature could be connected, or you would hear a really good group, nice piece of literature on the other hand that would give you contradicting sign. I'm not saying don't do it, I'm just saying do not take a comb beam just to look into your airway assessment. If you already have a comb beam for other features, or you were scrolling through it and you notice that the cross-section is really small in some area, then we probably want to maybe look closely and look into all the other features of the airway. ولكن just for airway assessment ما في literature كفاية يقول آخذ comb beam بس for that sole reason. هلا بالزمانات أيام ما أنا كنت أشتغل الماجستير والكوم بيم تبعي كنا نعمل هذا الحكي باليد, يعني سيمي automatic kind of a research point of view. بس هلا there are a lot of tools that can actually give you that in a much easier chairside type of way. فيعني التولز كلها في متناول اليد, بس we probably have to be a little bit more diligent in I would say interpreting the results. This is really interesting. وجود الكوم بيم والuse of the comb beam عم بعطينا a golden opportunity into actually understanding growth and development أكثر. وأنا عارف يعني you guys are the perfect group عشان to share my passion in growth and development. عشان ما حدا بيفهم ليش أنا بكون مبسوطة وأنا عم بطلع على السينكوندروسس إلا أنتوا جماعة الأورثو. So yeah, we could tell a lot more about our understanding of growth and development, and تعلمنا كتير من الكوم beams على الأورثوغناثيك سيرجري. يعني كل الليتريتشر تبع الريلابس والstability of orthognathic احنا عم يعني اخذناه من comb beam CT. And I'm saying that because I was يعني honored to be part of the stability study following orthognathic surgery, which was a really long-term process that happened at the University of North Carolina Chapel Hill. ورحمة الله عليه William Prophet was the head of that working group, or Dr.